Evening, aspirants and our honorable faculty. Today's class is about general topic of 𝑣𝒄𝒂𝒅𝒐 Part 1, which would be conducted by Dr. Srinivas sir. He is a chief intensivist at Ramdev Rao Hospital in Hyderabad. His area of interest are as follows: neurocritical care, extracorporeal organ support, and artificial intelligence. Over to you, sir. Now,
Good evening, friends, and thanks Farz Academy for having me over for this session on common topics, general topics. The scope of today's session is to talk about hemodynamic monitoring, talk about shock, a little bit of lactic acidosis, and then we will review something about scoring systems in the ICU. Majority of this session will focus on hemodynamic monitoring because that's the crux of most of the type A questions in EDIC Part 1. So I will focus a little bit more on hemodynamic monitoring and add on how you approach shock. Then we'll go to what is the significance of lactic acidosis, and we'll sign off with assessment and understanding of scoring systems in the ICU. Acutely ill patients come into the ICU mainly for either optimization of their oxygenation or optimization of their hemodynamic status. So this plays an important role in the management of acutely ill patient, and hemodynamic monitoring will help you in selecting the appropriate therapeutic options in achieving your goal of hemodynamic optimization. It can be a prophylactic tool as well in the perioperative patient, where you stabilize the hemodynamics and make the hemodynamics optimum enough for the patient to sustain a major surgical intervention. Multi-organ dysfunction syndrome arises from microcirculatory disturbances, but we, at this point of time, clinically relevant monitoring of microcirculatory system is not yet feasible. So when you talk about hemodynamic monitoring, we talk about monitoring the macro circulation only. So we will review the advantages and limitations of the available systems of hemodynamic monitoring, and we will discuss about the key principles to guide the choice of monitoring in acutely ill patients. So the gold standard for hemodynamic monitoring, even today, despite all the advances in monitoring and science, is thermodilution. Initially, we used to have the pulmonary artery catheter, but even today, we have several other methods which use thermodilution, which are compared against the gold standard of the pulmonary artery catheter. Invasive nature of the monitoring tool was the significant negative aspect of the pulmonary artery catheter, and you needed to have a significant learning curve for you to actually learn how to float the swan and how to understand the results of the pulmonary artery catheter. So it has fallen out of favor in most intensive care units, except those which deal with complex cardiac surgeries. Replacing the pulmonary artery catheter is a transpulmonary indicator dilution technique. We call it the PICO, the volume view, or the 𝒉𝒄𝒂𝒅𝒐, which are used as a surrogate for the pulmonary artery catheter. They use a hybrid of thermodilution and pulse contour analysis to give you most of the information which the pulmonary artery catheter used to give, and with reasonable level of accuracy. But what happens in the patient with pulmonary lung surgery, lung transplant, what happens to the patient with massive pleural effusions is something we have not been able to answer with this with the transpulmonary indicator dilution techniques. The only thing which these techniques do not give, as compared to what the pulmonary artery catheter used to give us, is the mixed venous oxygen, that is SVO2. Short of that, most of the numbers which we used to get from the pulmonary artery catheter, we are able to get with the thermodilution, transpulmonary indicator dilution techniques as well. The most popular, most commonly discussed, most commonly used tools, however, are the ones which are derived from the arterial pressure waveform. This is because arterial lines are routinely inserted in patients who are hemodynamically unstable, and the mean arterial pressure is still the method or the gold standard target for attempted optimization of hemodynamic instability. So you use the flow track, that is the Vigilio flow track, the most care, and a combination of the arterial pulse contour versus the thermodilution is what the PICO and LITCO are based. But for this, you need a optimum arterial tracing, and there are several caveats for the use of the pulse contour analysis, which we shall discuss during the course of this presentation. One of the entities which has come into the ICU in a big way and is applicable in a wide variety of situations is Can you mute your mic, please? So the one that is minimal, non-invasive is not can be applied to the patient as many times as possible, is easily reproducible and recordable, is echocardiography, which can be, but it's not a continuous hemodynamic monitoring tool. It is a intermittent hemodynamic monitoring tool, except the esophageal Doppler, which can be used continuously for 6 to 12 hours. But echocardiographic assessment of the right ventricle especially requires significant amount of tracing. Bioimpedance and bioreactance, we will discuss them, are emerging non-invasive tools which are being used in the intensive care unit, but they are not really validated in the general critically ill patients, say a patient with ARDS and septic shock, or a patient with cardiogenic shock with pulmonary edema. We don't know the value of bioimpedance and bioreactance as yet. So this is the cardiac output techniques which we have at our disposal. So what are the key principles of hemodynamic monitoring among critically ill patients? Critically ill patients are usually not straightforward. You don't have exclusive left heart failure. You don't have exclusive distributive shock. You will have an overlap. You will have a patient who has a distributive shock who is intravascularly volume depleted, but has subcutaneous and third spacing of fluid, which will interfere with your hemodynamic assessment. So the critically ill patients would present to you with complex clinical scenarios, and we still do not have an ideal hemodynamic monitoring tool. We don't have a hemodynamic monitoring tool that can be applied for all scenarios with equal efficacy and reliability. Therefore, intensive care or critical illness becomes the shopping mall for monitoring devices. So you have to have an armamentarium of devices which are connected to the patient, which to give you actionable and tangible information. So certain principles of hemodynamic monitoring, which all of you should remember, and you should extrapolate it into the questions you will face during the EDIC part 1. The first principle is no hemodynamic monitoring technique can improve the outcome by itself. So if the question is, which of the following hemodynamic tool has proven to be associated with better outcome, no single tool fits the bill. The outcomes, however, can be improved if the data obtained can be accurate to influence the therapeutic decision making, and it is relevant to the patient being the patient and the clinical situation that is being monitored, and changes in the management are made as a result of the data that is obtained, which to improve the outcomes of this patient. So the patient's clinical scenario, your application of the hemodynamic parameters, your interpretation, and the action you take based on the information you got from the hemodynamic data is what determines the outcome. No single hemodynamic number is associated with better outcome. The monitoring requirements may vary over time and can depend on the local technique, the equipment and techniques that are available, and the training of the operator. So the optimum monitoring is dependent on individual patients, and they should be used to complement each other. As I said, every hemodynamically unstable patient gets an arterial line. So this arterial line and a central line to give the vasopressors will give you some data like the mean arterial pressure and the CVP, and you can use that in conjunction with an echocardiography to tell you whether a patient needs fluids or a patient needs more or can accommodate more vasopressors. Now, when somebody asks you to define what is normal cardiac output, the answer is the output that is in sync with the patient's hemodynamic requirement. For example, an athlete who is running a 100 meters race, his requirement for cardiac output may be 10 to 12 liters per minute. For him, a cardiac output of 6 liters is abnormally low, whereas somebody who is sleeping will only probably require 3.5 or 3 liters of cardiac output. For him, a 4.5 liters is a high output. So the normal cardiac output is not a fixed number. Normal cardiac output is in sync or in tandem with the physiological state of the patient. So you have to look at the clinical situation, and then you have to understand what a normal cardiac output is. A normal cardiac output is determined by several aspects like stroke volume and heart rate. So the heart rate, the right atrial pressure, the pulmonary arterial pressures, the end diastolic volumes are all determinants of a cardiac output. And a low cardiac output is linked to abnormal lactates, abnormal mixed venous oxygen saturation, carbon dioxide gap, but most importantly, the surrogate markers of low cardiac output are an altered mentation, a low urine output, and a delayed capillary refill time. So this combination of determinants and downstream markers will tell you whether that particular cardiac output is enough for that particular patient at that point of time, given the physiological situation. So we need to assemble, understand, and integrate the variable. So you need to look at the preload, the contractility, and the resistance to the flow and tissue delivery to understand whether there is a low output or a high output. What we are trying to do with hemodynamics is to understand the contractility of a chamber, which also has an intrinsic muscular activity where, despite your volume status being normal, despite your vascular tone being normal, the cardiac output may be abnormal because the pump, that is the heart, is not working well. So the contractility plays an integral part in assessment of the cardiac output of an individual, and just not the heart rate and the systemic vascular resistance. You should always understand that hemodynamic instability and shock are represented by an imbalance between oxygen consumption and delivery. So the imbalance between oxygen consumption and oxygen delivery are reflected by the mixed venous oxygen saturation, that is SvO2, and its surrogate marker from the central line, ScVO2. While physiologically, the mixed venous oxygen saturation is a robust indicator whether the oxygen that is being delivered to the tissues is actually being offloaded or it is coming back unoffloaded. But in clinical practice, measurement and SvO2 targeted therapies have not been shown to influence the outcomes. A high cardiac output and a high SvO2 are not always the best. A high cardiac output is sometimes targeted, but that high cardiac output may be coming at the cost of a very high increased myocardial oxygen demand, which itself can trigger an ischemia. A very high SvO2 would mean that the oxygen is not getting offloaded in the tissues, so there is a uncoupling of the electron transport chain in the tissues, and is usually a bad sign or a sign of worse outcomes when compared to a low ScVO2. So this is another point you need to remember. The cardiac output is always estimated and it is not measured. You can't actually get the exact cardiac output, but using certain markers like the stroke volume, the heart rate, the peripheral vascular resistance, the contractility, you calculate it. It is not a measured. You don't give a fixed number straight away. So you will look at the decay in temperature, the decay in the dye versus the amount of flow versus the heart rate, and then you understand about the cardiac output. The comparison of measurements obtained with different techniques are not the same. So suppose I put a pulmonary artery catheter, I put a PICO or a 𝒃𝒄𝒂, and I put something else that measures non-invasively the cardiac output. The numbers which we get by each of these techniques is highly variable. It can range from 3.5 to 6.5 liters in a normal person. So you need to understand that it is a trend in cardiac output, and a single tool has to be used to look at the trends, and you can't be interchanging different tools and interpreting the numbers as they come. So following the trends is probably the best way of monitoring cardiac output and hemodynamic optimization. The monitoring of hemodynamic changes over a short period of time is very important, because the functional hemodynamic monitoring, like systolic pressure variation, the pulse pressure variation, the stroke volume variation, they are all things which have to be interpreted over a short period of time. If I give a fluid bolus to a patient now, I should be able to assess the effect of this fluid bolus in the next 10 minutes, not after 1 hour. The effect may be not visible after 1 hour, in which time I would have missed an opportunity of giving this patient more fluid. Intermittent modalities like echo, while they are useful, they are not the most reliable method of assessing somebody's hemodynamic status. So continuous measurements are preferred, like cardiac output, mean arterial pressure, and central venous pressure. There is no evidence to suggest that intermittent techniques are not comparable to continuous techniques, but if you have a continuous monitoring, at least you will tend to act on it in a shorter period of time. More and more emphasis is being placed on non-invasive hemodynamic monitoring tools, but non-invasiveness is not the only issue when you look at these patients. You also need to look at the reliability and the applicability of these tools to that particular patient's clinical situation. Echo is more useful for assessing the overall cardiac function of the patient, being a non-invasive disease, but pulmonary artery catheter is probably the most informative when it comes to understanding a patient's hemodynamic status. So the optimum device for hemodynamic monitoring tool at the end of the day, represented by the type of patient, the question that is being asked, and the clinical situation in which you are applying the tool for assessment of hemodynamic optimization. So we can conclude with for the first half of this discussion on hemodynamic monitoring by saying that one size does not fit all. You should be familiar with the technology, its advantages and limitations, and hemodynamic monitoring can be very helpful in initial resuscitation, and monitoring would give you data which will help you to influence your intervention. So this is the summary of hemodynamic monitoring. So we will look at minimally invasive hemodynamic monitoring, so that because those questions keep coming very often, because the invasive ones are very commonly used, so everybody knows about it. The minimally invasive ones are the ones which are coming into vogue at this point of time. So let us put some emphasis on minimally invasive hemodynamic monitoring tools. We all have understood that PA catheter is the established gold standard, and fluid therapy and vasopressors are used based on the information from monitoring tools. So you have minimally invasive and non-invasive tools, and you have intermittent tools and continuous tools. So if you look at the invasiveness of hemodynamic monitoring, the most invasive is pulmonary artery catheter. The less invasive or transpulmonary thermodilution using the EV1000 or the PICO or the LIDCO. The minimal invasive ones are the pulse wave analysis using an arterial line, so the so-called pulse contour analysis, esophageal Doppler, NICO, partial rebreathing of carbon dioxide, which is again a marker of cardiac output, and transesophageal echocardiography. The non-invasive ones are using the transthoracic echo, using bioimpedance and bioreactance, and using finger probes to assess the pulse wave transit time, called pulse wave analysis. So this is how you classify hemodynamic monitoring into highly invasive, moderately invasive, minimally invasive, and non-invasive. So when you look at the whole system of hemodynamic monitoring, patients may require hemodynamic monitoring in the ward, emergency department, operating room, and in the ICU. In the ICU, the role of transthoracic Doppler non-invasive pulse pressure analysis is probably less. As the patient transitions from emergency room to OR to ICU, the role of transesophageal Doppler, the fixed principle, the thermodilution, the pulse pressure analysis, and the pulmonary artery catheter actually increases. So the sicker the patient, the more exhaustive and the more invasive your hemodynamic monitoring tool would be.